We're honored to welcome you all for this groundbreaking forum. And I'm especially honored that, if I could find where we are here, that my friend, Kathleen Sebelius, former Secretary of Health and Human Services, is here. She knows the summit's issues inside and out, not just because she served this country as the Obama administration's top woman on health care, but also because she served the state of Kansas as its second governor who happened to be a woman. We're fortunate to have Susan Dentzer, whom many of you know from her years reporting for the PBS NewsHour, as our moderator for today's conversation. She currently serves as Senior Policy Advisor to the Robert Wood Johnson Foundation, the largest foundation in the United States dedicated to American health. So please join me in welcoming both of them now.
Now, while these ladies get situated, I just want to say, as the new director of the Canada Institute, one of my first jobs, Jane, is to try to get rid of these directors' chairs for women, because they're a really bad idea. So on behalf of the
Unless
Canada
you're smart
Institute,
enough to wear pants like the secretary.
either that, or we're going to supply tablecloths for the ladies. You can just put one delicately over your lap.
Great.
Been here before in the director's chairs, hence.
Well, thank you, Laura, and thank you, Jane, for that nice introduction. So, as you know, all day we've been talking about comparisons between the U.S. and Canada, and Secretary Sebelius, and I was thinking back, one of my favorites, I don't think was mentioned so far, it was back in the early 90s, and there was a Canadian comedian on television here in the U.S. trying to explain how much befuddlement he encounters when he comes here and says he's Canadian. Americans don't really understand Canadians. This will not be a shock to many of you in the audience. And so he said, it's very simple. This is how I explain it. A Canadian is an unarmed American with health care. So speaking of public health issues, Secretary, as you know, we have so much in common with our friends in Canada. We have this long border in common. We both have programs called Medicare, although they're very different, as we heard again today. When you were Secretary, how much contact did you have with Canadian health authorities? How much interaction was there at the ministerial level, in our case, the departmental level, between the two?
Well, I will respond to that. I need to start, though, by thanking Robert Wood Johnson for being part of this, certainly thanking the Wilson Center and the great leader, Jane Harmon, for organizing this. I was surprised to learn that this kind of summit has never happened before, so I think it's a very important dialogue. And Susan and I have known each other for a number of years and worked on health issues. I also have to apologize if I don't put verbs in all of my sentences. I do come out of Kansas, and the Royals are our team. Anybody who's a baseball fan who stayed up and watched them, they are the champs.
Hear,
so
hear, hear.
Just saying. But it was another late game. My first experience as secretary actually happened before I was secretary, which was during the outbreak of H1N1, and I was still the governor of Kansas, and we had a very careful plan about being voted on by the Senate, which was going to start on the 28th of April. I would then resign as governor, get the lieutenant governor sworn in, fly to Washington, start my new job. And the debate started on the Senate floor that morning. I got a call from the White House saying, there's a plane in the air. It will arrive in Kansas at noon. The president wants you on the plane. I carefully explained that we had a plan, and here was the plan, and the caller was not amused and again said, there's a plane in the air. The president wants you on the plane at noon. I said, I don't have a job. I haven't been confirmed. Plane in the air, be on the plane. So it was a reminder, first of all, that I had a boss again, which was a little interesting. And I left literally a note card on my desk in Kansas that said, "In the event I am confirmed, I hereby resign as governor," because I really didn't want to do it preemptively. Flew across the country. I was confirmed in the flight somewhere along the way. Arrived, was taken right to the Oval Office. The president swore me in the Oval Office, and I went to the Situation Room that night and was on a phone call with the health minister of Canada and health minister of Mexico and the director of the World Health Organization, because this outbreak of H1N1 was, we thought, coming out of Mexico. Nobody really knew. There were cases in the United States and in Canada. Sharing information was critically important. There was no vaccine. There was no real identification of what was happening, but we knew it was targeting and deadly to a very different population. Children were dying, young people were dying, which was a very different look of the flu. So I started day one, second one, working very closely with my Canadian colleague, who at that point was Leona Aglukkaq, who had been a long time predecessor. She'd been on the job for 6 months, so she was by far senior to me. But that relationship was incredibly important, and the health minister of Mexico. But the notion that the Americas share a lot of issues, but certainly a lot of health issues, was clear from day one.
And that led to a more formal agreement among the three countries around cooperation around public health and disease surveillance in particular, did it not?
It did, and I think one of the things that was incredible during that time was Mexico, who the country really stood to take the biggest hit, because it became clear that that's where H1N1 started. And their willingness to be totally transparent, to give information, and actually to then take some activities in that country to close beaches and close towns for a while until they figured out what was going on, was an enormous act of generosity to the rest of the Americas, but certainly the rest of the world. But it became clear that we had to communicate very openly, very transparently, that there were several different countries working on vaccine, that we needed to share that information, share strains, get disease information between the countries very, very quickly, and ultimately to the rest of the world. But it was critical that it happen across borders very fast.
We had some interesting discussion on a panel this morning around health information technology. And of course, as secretary, you presided over the rollout of the high-tech law and so forth. It's interesting to think about the anomalies, because in the disease surveillance space now, clearly we have a cooperative framework around sharing of information and information flow. In the electronic health records sector, apparently we run right up against the Patriot Act, and sharing information across borders about individual health care through an EHR is not possible. Without necessarily asking you to comment on that particular situation, what kinds of arrangements exist between the countries to work through these issues? What did you find when you were secretary in terms of your ability to, can you pick up the phone and call your fellow health minister and work these things out, or how does it work?
Sort of. The phone call can always happen, and that works very well. And the dialogue, I think, works extremely well. The problem is there are embedded laws that were written before electronic records existed, or before researchers even wanted to exchange information. So working around that, making accommodations, working around trade agreements, barriers to information flow is a constant issue. I think, you know, the United States finally is implementing the ICD-10s, the international codes for disease identification, which will be a big step forward. In many countries, they've been in place for 35 years.
And many are already working on ICD-11, as you well know.
I understand, but we're finally there, and having the United States finally code in the same way, I think it would have been very helpful if that had been in place when the Ebola breakout started, so people had the same identification of the same issues. But I think in both, Susan, not just day-to-day activities, but there's been, starting after September 11th, there was a global health security group put together, and Canada is very much a part of that, as is the United States. There are subsequent now 40 nations at the table around a global health security agenda, which recognizes that a disease outbreak anywhere affects people everywhere, and that we need a much more nimble, much more flexible, much more aggressive way to share information, but also to identify outbreaks at the source, to actually send teams in to assist in countries where there isn't enough infrastructure. And that, again, the partnership between the United States and Canada has been extraordinarily strong, and a very keen leadership role around those issues has been important from this area of the world.
One of the things that we share in common, the U.S. and Canada, are some real pressing health issues for the population. We both have about 2/3 or more of our adults in each country overweight or obese. We're winning, rah-rah, the U.S., we're winning in obesity. They're winning in overweight, but we're close, right? You have been involved in some efforts on the part, but the First Lady's initiative also has had some cooperation from the Canadian authorities. Talk about that, and talk about whether there was really a common approach on some of these shared public health issues.
Well, absolutely. First with, as I say, the initial health minister, Leona Aglukag, who I had the opportunity to work with, and continuing on with Rona Ambrose, the current health minister. There was a lot of collaboration and cooperation, not just around diseases and health security, but certainly the demographics of our population, and the amount of time and energy and actually prosperity is dedicated to trying to deal with chronic disease. So looking at obesity and smoking were the two areas that underlie a lot of chronic disease, and sharing what we're doing, what works. There was a lot of interest in Canada, but I would say also across the globe, in having the First Lady, having the partner to the country leader take on an issue like childhood obesity, which raised it to a very different level. It wasn't a health minister issue, it was really a head of country issue. And I think Canada was very interested in how that worked. Certainly there was a lot of dialogue about how that could be replicated, as I say, in Canada and Mexico, but also in various European capitals. So we shared information about the underlying theories, but also lots of research projects are going on together, lots of look at public health issues. I think everybody kind of recognizes that the air we breathe and the water we drink and the food we eat and where we live and work and play has as much to do with health as anything that happens in an interaction with doctors and hospitals. So the attention to social determinants of health, how you can actually make a difference in people's lives. And I know we shared a lot of information. Leona Aglukag was an Intuit and came out of a small population that had the same kind of health statistics as our Native American, our first American population. So we shared a lot of information about how to deal with the most vulnerable, often the most disregarded populations around health issues.
Did anybody in Canada ever press you for why we export so much fast food to Canada?
Well, get in line. We did talk about, and I'm a big believer, this has not happened yet, but maybe those of you who are still in the health biz in both countries, That, to me, is a global discussion that really needs to happen. We pressed a bit under the umbrella of the World Health Organizations, but when you think about the food manufacturers who are selling product, they sell it globally. These are global companies, and they have done a pretty good job, I think, of divide and conquer. So the cornflakes sold in the UK are different than the cornflakes sold in America. They have less salt, they have less sugar because the UK has a standard that we don't have. It's clear that they can make them that way, they will sell them that way, but they won't do it unless there's a global dialogue. And I think we're missing a piece there, that we don't leverage all of our interests and go to, you know, whether it's the soft drink manufacturers or the food processors, and have a global standard for health and for trans fat and sugar and salt particularly, and begin to take them out of processed foods. That would be really helpful. Okay.
Another global product of interest to our two countries is pharmaceuticals. I remember back in the 2000s, when at the height of the importation debate here in the U.S., there was a lot of desire on the part of many governors and others to re-import drugs. The phrase was re-import drugs from Canada, but it turned out in many instances it was just going to be sheer importation. And when I went up to Canada, the Canadians didn't think this was such a hot idea, since they consume 2% of the world's drugs and the U.S. consumes 40% of the world's drugs. So us taking the 2% out of Canada was not their favorite idea, and bringing it back to the U.S. That particular issue aside, what kinds of cooperation, collaboration took place around pharmaceuticals? Regulation, we have very different systems of price regulation, in our case, not so much. What kinds of discussions, and what kind of discussions do you think should take place going forward as we now talk about the issues of very high-priced specialty drugs imposing really high cost burdens, in particular, on our system?
Well, I know you have a panel, I think later today, or maybe it's already occurred, with some of our FDA experts, and there was certainly a lot of regulatory dialogue around how products are regulated, including pharmaceuticals, and very little dialogue around prices. There was a lot of discussion that we have different systems, but I was surprised to learn that Canada, whose universal health dedication I have long admired, that pharmaceuticals are really out of that system, and that pricing in Canada is becoming a hotter and hotter topic as drug prices go up, because a lot of people are paying for drugs independently of their government health plan. In the United States, as you know, Susan, and many people know, the FDA appropriately is forbidden by the law to look at pricing decisions when they approve or disapprove drugs. And I think that's absolutely what we want. We don't want a drug to be prohibited from coming on the market because of a potential cost. The problem is we don't have anybody else who has any authority to do that in the United States. So we end up, I think, not only as consumers paying in many ways at the front end for NIH research as taxpayers, having drugs developed in this country, and then our consumers end up paying the by far the highest prices of anybody on earth to purchase the drugs that they helped to invent in the first place. And that's, I think, a growing perfect storm in the United States, where you can now, with transparency and people are watching this dialogue, I think that the president's request, which has been made for the fourth year in a row in his budget proposals, to have authority to regulate or negotiate for Medicare drugs. The VA can negotiate, Medicaid can negotiate, the Defense Department can negotiate. Medicare, who's the largest government purchaser, cannot negotiate.
And specifically, the secretary is forbidden from negotiating.
You bet. You cannot. So I think there's, and in Canada, I think the pricing issues are also growing stronger. So this is a likely topic that will be kind of a hot topic in the future. I don't see anything changing in this particular Congress, but I think there's a growing storm of consumers, doctors, patient advocates, and insurance companies, interestingly enough, who are now sort of after drug prices, and that's likely to create some change in the future in the U.S.
So one of the great lines uttered today was that of Sherry Gleed, who was Assistant Secretary for Planning and Evaluation.
She was indeed.
And Sherry said that every healthcare system in the world is completely insane, no matter where it is. All healthcare systems are creatures of the local culture, political ideology, all kinds of other things that get rolled into the system beyond just clinical care and healthcare. Without asking you to comment on the insanity of our system, let me just ask you, as you obviously lived out the early days of the Affordable Care Act, and even leading up to implementation of the Affordable Care Act, was there any effort to try to learn about what is going on in Canada and use that to inform any aspect of implementation of the law or other aspects of delivery system change and reform?
Well, I think all of us had Canadian envy. I would start there. The notion that you could have a system of universal coverage, first of all, which was one of the underlying goals of the Affordable Care Act from the beginning, but done in piecemeal fashion, and some sort of a rational underlie for payment was always something that informed efforts. What the president decided early on, and it's kind of amusing to be a bit outside, and when people say to me, well, why in the world don't you have a universal coverage and single payer plan? And I just want to walk them through what is a near explosion of political battles over what is really a private sector, privately run, privately operated plan that passed in this country. And any notion that we could have gotten to a single payer plan and wiped out 180 million people's insurance coverage and started again is just not very realistic. It would have been lovely. In the long run, would you design a system that looks like the United States system ever in the world? Nope.
That insanity world comes to mind.
Insanity world is front and center. So we always were informed by Canada and a number of countries, and the data is pretty stark. I mean, Canada spends about half per capita what the United States spends, half, and has better health results. Now, Canada's system may be insane, but that, to me, looks much more sane than what we're doing, which is double per capita, almost 18% of our GDP, and the largest number of uninsured plus really mediocre health results.
Another point that Sherry made was that one other feature the U.S. and Canada have in common is we think we're the only countries out there. We don't tend to learn very much from other countries, whether it's countries in Scandinavia, even developing systems. And that one of the unfortunate manifestations of that is that we've built our systems off of fee-for-service. We both neglect primary care, by and large. We reward our specialists much more handsomely than the Canadians do, but nonetheless, the ratio still is skewed in the direction of specialty medicine. What opportunities do you think exist for us to collectively work our way through a greater understanding that there are other countries to learn from?
Well, I think that's a great point. I'm not sure that there's a great opportunity in the near future to redo the sort of insurance side, enrollment side of our puzzle until we really get a system under everybody, and then maybe you could flip it. But I think there's a huge opportunity around delivery system reform and around really paying attention to moving from a sick care system to a health system, sharing information about what works, looking at primary care docs and others are rewarded for keeping people healthy in the first place and not for the number of interactions they have with an acute care system. And information exchange and social information exchange, looking at what really changes hearts and minds, what changes behavior, and particularly how you get some dramatic shifts in smoking rates and in obesity, I think is a huge platform opportunity for both of our countries. And there's a lot of interest in doing that, I think, and a lot of effort that can be built on. And having, the United States moved from really a pen and paper file system in 2008 to now an electronic platform. That makes a big difference. So you can actually, we don't have to make policy by anecdote anymore. My aunt did really well with this doctor, so I really think he or she is the best. You can actually measure things and look at things and compare information. That's going to make, I think, moving ahead, not only with Canadian partners, but globally, a lot easier and a lot more realistic.
We do want to open this up to questions or comments or even short speeches masquerading as questions from those of you in the audience. So let's go right here. And if you would introduce yourself by name and affiliation, that would be great.
Of the TPP on any possibilities of pharmacare?
Well, I think to your point about Vermont, one of the things that is written into the law is that states who want to put together a across-the-board system for coverage in their states, which would include all of the federal programs, all the state programs, all the private insurers, and look at really an all-payer, all-size-fits-all system, have the opportunity in 2017 to do just that. And so that was always part of the framework, much like, in the Canadian system, the provincial governments actually are the authority over healthcare. A lot of the healthcare in the United States is still under state jurisdiction. The insurance markets are, most of the plans sell regionally and locally, so a state is well equipped to figure out the puzzle, and I think Governor Shumlin in Vermont has done a very interesting job, and there are other states really on the far edge of experimenting with more of a universal look, so I think that will come. And the federal government's history is once about half the states are doing anything, then a law is passed in Congress and they take credit for being at the front edge.
Spoken like a former governor of a state.
But states are great areas for innovation and incubation of new ideas, and I think that will continue on. TPP has some potential. I think clearly the pharma companies were not happy with the way the TPP ended up. I think that the issues about using the trade law to actually sue, to block cheaper priced drugs, to evergreen brand names into the future, to keep life-saving drugs out of the hands of poorer countries is very dangerous. And so I'm hoping that that provision stays, and I mean that the TPP passes as is. It probably isn't as strong as some would have liked, but it's a big step from where things are now, and I think a very important battle that this administration is willing to take on.
Other questions, comments, or short speeches? Well, let's talk. I brought up did I see another hand up there? I brought up the whole question of guns. As we know, the Centers for Disease Control and Prevention here has been forbidden to conduct research on gun control, gun legislation, and the connection to public health and public safety. We have lived through, as you well know, several of the worst years in memory in terms of mass shootings here in this country. What, if anything, can we learn from Canada on that score?
They're much smarter than we are. I mean, I think what goes on in this country around guns is horrifying. And the lock that the NRA has on elected members at the legislative level, at the gubernatorial level, at the congressional level is terrifying. Most people, I mean, I come from Kansas, and Kansans have a strong hunting tradition and gun tradition and cowboy tradition. But in a state like Kansas, there is a recognition that there's a distinction between hunting and sport shooting and killing people with a semi-automatic. In spite of that understanding, I think legislators get frozen in their tracks. I used to, as governor, lead what was the one-shot turkey shoot. I'm sure all of you have participated in a one-shot turkey shoot. I frankly was a city girl. I didn't know how to shoot a shotgun. I learned how to shoot a shotgun. I actually have a turkey in the Turkey Hall of Fame. Who knew there was a Turkey
Alive?
Hall of Fame? But no. I would have preferred that, but no. But I would wear my camouflage and veto the bill on conceal and carry every year that it passed when I was governor, to just indicate that, okay, I know about guns. I'm going out to shoot my turkey, but I'm not going. And standing behind me always were law enforcement officers, the chiefs of police, the sheriff's association. Would like nothing better than to get guns off the streets of America. And I think we just have to be willing to stand up as citizens and demand that our elected officials get some backbone and just say no more guns, and learn from our neighbors in Canada and our neighbors across the globe that having more guns really does not do anything but have more people killed by guns.
Do you think it would be realistic to suppose that you could at least overturn the prohibition against the CDC conducting research on this question?
Well, again, it's been voted on a number of times. The proviso keeps being added to the budget. It's, again, an outrage that you can't even, frankly, the CDC, I think, continues to collect the data. They are prohibited from talking about the data, which is really very helpful. Because I think it puts into perspective in emergency, we get headlines with some mass shootings, but if people had any idea of the number of people with gunshot wounds and near-death experiences and deaths that come into every emergency room on a regular basis, how many domestic violence situations end up with guns, how many people influenced by alcohol go get a gun and shoot somebody else. It is terrifying, and this actually would put it into some perspective beyond the periodic horrific mass shootings that end up in the newspaper. But again, it's an act of Congress that they vote on each time, and the majority keeps in place, and the president has no line item veto, so it stays in the budget.
We can measure almost everything else about health care, but not that. Let's take a question over here.
Some of us from north of the border look at some of the leading U.S. systems like Kaiser, Group Health, Intermountain with actually a bit of envy. But also, maybe, or at least for me personally, some surprise that these systems don't expand faster in the U.S. I wonder if you might comment on why these systems haven't expanded as fast in the U.S. As they might, given their quality scores, et cetera.
Well, I think the expansion issue may be more related to their business decisions. Part of what they have done is built centers of excellence around the hospital system, certain doctors, certain employers, and it isn't something that could be just automatically transferred. Now you see some branding going on, so there is now the Cleveland Clinic brand in appearing in various parts of the country. Mayo has some collaborative partnerships with systems in other parts of the country, but that is a pretty detailed scrutiny of what it is that they're lending their name to, and how the quality measures actually match up. I think what some of those folks are cautious about is, this is a big 330 million people country, and to just sort of say we're suddenly going to buy up various systems and various hospitals and it will automatically match what we're doing here. They have made the decision that that's really not terribly easy to do. The good news for a lot of U.S. health systems, though, is that information is being shared on a much more real-time basis now than it ever was before. What is it that you're doing? Why is the care so much better? What is the quality issue that distinguishes you from others? And trying to replicate what they're doing is actually happening, I think, in more systems around the country. They may not have the name, they may not have yet driven the numbers, but it's certainly, I think that effort in delivery system reform is really picking up.
And given Secretary Burwell's now commitment to move the system even more away from fee-for-service.
And CMS, as Susan has said, has a very specific and transparent timetable. In 2011, 0% of the CMS payments had anything to do with quality, 0. They are now at 30%. The goal is to be at 50% by the end of 2018. That's a huge sea change in a health system that touches every hospital, every doctor, every drug company, every device company. And if they can do that, we'd be at the tipping point where quality measures become the measure of pay, and we finally would have financial incentives in this country aligned with outcomes, and that's never been the case before.
Secretary, you've been so generous with your time as we move to close this wonderful conversation. Everybody would like a redo in life. If you had to get a redo on your tenure as secretary, in thinking in terms of what you might do, what you might have done more of internationally, whether it is by dint of working more closely with Canadians, other countries, what might you have done differently if you had a chance to do it all over again?
Well, I think, unfortunately, for a lot of us, global health issues, even with our close neighbors, become secondary to whatever's coming over your transom at the moment. And we certainly had a lot coming over the transom during my tenure. What I think was clear from my first days in the office, from my last days in the office, and everything in between, is more frequent, more constant dialogue, learning, stealing good ideas would actually cut down on time and energy spent reinventing the wheels. So somehow to have a more routinized way to get global information, to have a monthly call with the Canadian health minister that just is, what do you know? What should I be doing? What's the best idea you've had this month? How can we steal it from you, and vice versa? Probably would be a great way to spend some time and energy. It tends to, again, be out of sight, out of mind a little bit in periodic gatherings, but some way to actually make sure that that happens on a much more routine basis, because we're dealing with the same issues. We all have the same outcomes and goals, and the more we can cut time and energy by sharing that information, I think the better off we'd all be. More healthy, more prosperous, and that's a good deal.
And what a perfect note to end on here at the U.S.-Canada Health Summit. Join me in thanking the Secretary for a terrific discussion.